Good morning, everyone. My name is Councillor Karen Chappell. I'm the Acting President of the West Australian Local Government Association. I have by my side the CEO, Nick Sloan. I would like to acknowledge the traditional owners of the land on which we meet today and pay my respects to their elders past, present and emerging. Thank you for joining us this morning. The large number of people registered for today's webinar shows the keen interest from the sector in ensuring that we are armed with as much information as possible on this important issue. Our aim is to provide local governments with information on the WA Country Health Service preparedness and planning for COVID-19 and an opportunity for some questions and discussion. Provision of health services form an acute challenge for our country communities, and I'm very grateful to the representatives of WA Country Health Services and the Department of Health who have joined us today via Zoom to share their knowledge and planning in the context of this pandemic. Our first speaker this morning is Dr. Helen van Gessel, the WA Country Health Services COVID lead. Unfortunately, Dr. van Gessel has to leave us at 10:30, so straight after her presentation, we will have a short question and answer session. Please type your questions into the chat at any time. Thank you to those who submitted questions via email. We have a copy of those and will ensure they are incorporated into the Q&A session. Please join me in welcoming Dr. Helen van Gessel.
Hi, everybody, and thank you for having me. I think I can manage my slides from my end if that's all right, so I might share my screen. And also, and I didn't let you know beforehand, but I've cancelled a meeting so I can stay later. So you've got a bit more flexibility, which hopefully is good. Actually, I can't share my screen because that's disabled. So maybe the host screen can then present. So I've updated my slides. Okay. All right, so sorry about that. We'll see how we go. So yeah, my name's Helen van Gessel. I'm an infectious diseases physician by training. I've been living and working in Albany for the last 11 years or so, but for the last couple of years have been working primarily with WA Country Health and our central team on our COVID responsiveness and COVID preparation plans, which obviously have continued to change and evolve over that time. So the next slide would be great, please. So over the last couple of years, obviously there's been different stages in our response, and early in 2020, we had the largest community outbreak of COVID in WA, which was up in the Kimberley, and many of you will remember that. And there were multiple case clusters since then. But really since then, like the rest of Western Australia, we've really had experience only with sporadic imported cases only. WA Country Health has very many and reasonably unique roles in WA in our COVID response compared to other health service providers, in that we are a service provider, and obviously for COVID care, but really critically for non-COVID healthcare services as well, and across that whole spectrum of care, of acute and community and aged care and mental health, for example. So a major healthcare service provider, but also, and Catherine will talk about this more in the state response, we're also the hazard management agency, so also have that direction of response at a regional level responsibility. Our public health teams are working in our regions, but work closely with the central public health response team. And we also have a large responsibility for testing capacity, which is a little different from the metropolitan testing capacity, which has got obviously a much more diverse range of testing with private pathology and so on. Next slide, thanks. So Catherine will talk more about this, but in the emergency management type of framework, there's obviously a state level response and then the HSP, so our health service provider, so that's where WACS is. We've had an emergency operations centre stood up for the last 2 years. It has evolved and changed over time and flexed as we need, but there's also at a regional level, the regional directors lead that regional response. So this is this delegated role of the hazard management agency to the regional director at that level. So, and then at a local level, there's also LEOX. So there's those sort of standard emergency management frameworks for response and levels of escalation through that. And from a country health service point of view, we're really covering the 4 circles at the bottom, if you'd like. Next slide, thanks. So we've focused on a number of preparedness activities. Some of them are really focused on the individual and our staff members. We've got over 10,000 staff across the state, and we all have to be obviously ready as a frontline responding agency. So we're really focused on how can we make sure our staff are as ready as possible. So that includes all the obvious things you would think of vaccination, our PPE training and equipment, fit testing, all of those things to make sure our staff know what they need to do, but also have the equipment and training to make sure they can do it. We've been working a lot with teams on drills and simulation. We've had rapid deployment teams working on upskilling. So again, all the things you would expect to see in an organisation of preparedness. And also working a lot with community and partners, and many of you who will be in the room have been part of your OASGs at a regional level, but also lots of other agencies. We meet regularly with the ACCHO sector, with WAFA, with our transport provider partners, so a whole lot of people working together because none of us can do this individually, obviously. And the next slide, thanks. I did want to just say, because I can't give a talk and not talk about vaccination. I know you will all know this, but from a preparedness point of view, from a health service preparedness point of view, vaccination is still the most important thing we can do in our community. So this graph just shows the rates of death and ICU admission in New South Wales by age group, and the blue bars are the rate if people are vaccinated, the red bar is the rate if people are not vaccinated. So it really just reinforces that at every age group the risk is less if people are vaccinated. So we've been providing, WAC's been a major provider of vaccination throughout country WA, working really hard with GPs and AMSs and the government and so on to make sure we can get as many people vaccinated as possible. Next slide, thanks. But really the main focus of, not the main focus, one of the main focuses of our aspects is thinking, because we've had individual and team preparedness and so on, but we've done a lot of work on service preparedness because WA Country Health is a whole of service. So we have regions, but we really want to be working together. Every site now has patient flow and surge plans, so they know where, if a COVID patient needs to come in, where they would go, what's the best bed for them to be in. Also, if they get more patients than expected, how could we have a surge plan capacity as well? They've also got service continuity plans. We've been doing a lot of work on ventilation. So this is the air conditioning type ventilation. We know airflow is important within buildings. Our larger hospitals have now all had, and we're working through many others to make sure all the ventilation has been assessed, and we've had upgrades where we need to. We bought a lot of new equipment to really, again, think about safety for patients, safety for staff, and our preparedness. As I said, our other sort of service preparedness we've been focused a lot on what we can do centrally to support whichever region and whichever team needs it. So we've really tried to grow those central, particularly telehealth-enabled services, because they can be flexible to fill gaps if need to, but to support clinicians on the ground. So we now have services providing emergency telehealth, inpatient telehealth. So that's to people that are inpatients in hospitals. Cancer care, so cancer telechemotherapy. Our palliative care teams have had big increases in staffing, but also in their technology they can provide care to people's home directly. Mental health telehealth, maternity and obstetrics. And our most recent part of that is having a coordination team based centrally, working with St John's and RFDS to be able to really make sure moving patients around, which is challenging now, and we're anticipating will be more challenging when there's a system under stress, can be done as well as possible and as coordinated as possible, and as efficiently. Next slide, thanks. I think we've all had a big change in our settings in the last month and a half or so. This is the modelling that was done for the expectations of a Delta when we opened the borders on February 5th. The peak number of cases per day in this model was 350 cases per day. And if we just go to the next slide, Omicron really has changed all of that. It infects many more people much more quickly. And so even though the illness is mild, when you have many more people infected, there's still an increased need for health services and so on. Just want to reiterate, of course, that vaccination is still effective in Omicron, which is why we've been really conscious of keeping on pushing that. But we know that Omicron is more challenging to control. So it really has changed a lot of our planning and the response plans for that in the last 6 weeks or so. Next slide, thanks. So we have looked to South Australia particularly because they are similar jurisdiction to us in many ways and look particularly in some of their country areas to see how they're tracking. The graph here with the blue bars is that's their case numbers in South Australia, and they were expecting to track along. That top black bar was their sort of expectation of cases, and you can see that the blue overshoots that in the week before Christmas, which was when Omicron came into South Australia. So it really shows that those existing models just don't hold true for Omicron. But if you look on the next slide, thanks, they redid their modelling looking at those kind of at the new settings, and found a couple of really interesting things I think for us to remember. One is that masks, and those PHSM is public health and social measures. So masks and vaccination and so on really made a big difference to what they were expecting to see. They put them in place quite quickly, I think it was Boxing Day, and made a big reduction in the cases they were expecting to see. And so recast new projections. And so they were projecting for them in South Australia about 370 patients in hospital at peak. So we could apply that in Western Australia, but actually they've done better than expected, and it's a little less than that. So I think we're still watching and waiting and seeing how that's panning out. Next slide, thanks. So we're really interested as a country health service from the regional health experience, and we've been in touch with colleagues in a number of different states and regional settings to really try to understand how their health services have responded, what their challenges have been, and what we can learn from them as well. There's some really common themes there that with Omicron in particular, there's much more impact in the community than Delta, and so staff furlough for every industry, including the health industry, is a really a major issue and much more prominent than before. More people are able to remain in their local hospital with Omicron than they experienced with the Delta infection. So people are often, because their illness is not so, when people got sick with Delta, they got really sick from a respiratory point of view, so needed intensive care quite quickly if on that most severe end of the spectrum. That is much less common with Omicron. So there's more people in hospital with Omicron who also have an injury or have a urinary tract infection or have an intercurrent illness or relatively mild and need some oxygen for 24 hours, for example. And those kind of people are usually the cases that we keep in our local hospitals. And that has been the experience in other regional hospitals as well, that because people aren't needing, in general, obviously, that really higher level of care, there's been many more cases able to be cared for locally. The other thing that's been interesting to note is that the Omicron there hasn't been any regions spared, if you like, of not having any cases, but the impact has been very different at different regional areas over time. And we can imagine in a state the size of Western Australia, it's really unlikely that we'll all be experiencing the same peaks, if you like, of cases at exactly the same time. And there's going to be a lot of local variation, which we'll be having to manage through with partners such as yourselves, obviously. When we have talked to the regional health services, though, they really emphasise that these were major challenges, but they could manage through them. And the common thing that they all said was the local relationships and being able to respond to things that are unexpected and occur was absolutely the key thing. So they all had good plans. Some of the documented plans weren't necessarily as useful as they anticipated because circumstances changed quickly, but the relationships behind getting those plans together and the conversations they'd had and the equivalents of our OASGs and those kind of groups were incredibly important. Next slide, thanks. So if we think about from our health service point of view, we're expecting significant impacts on our workforce because of staff and members of the community as well, obviously, and so also get sicker in isolation. At the same time, there will be more patients admitted with COVID into our hospitals. And we all know also we have background workforce pressures already. So this is a really major stress point for us now, and we're very conscious that it's also affecting our communities as well. So this is similar everywhere. We are expecting the furlough policy. So that's if there's someone's a contact, for example, of a COVID case, there's a pretty rigid application of a 14-day isolation period in general, and that's already been some modifications allowed for healthcare workers that are exposed in the workplace, and we're expecting further modifications around that when we get more case numbers as well, to be able to balance that risk of COVID and the risk of service impact. So that's going to be an ongoing sort of balance as well. So we need to plan ahead for that. Next slide, thanks. Part of our planning for our response, and you might start to see some of these things and some of this terminology if you're going to the hospital or talking to hospitals in your communities, will be the system alert response. So people are now calling it the SAR. And this is going to be overarching guidance for our hospitals that reflect in each local area. And we understand it will be by region rather than local government area. Will be at a certain stage of response from that green, amber, red and black. And the responses and actions will line up with that. So, for example, the PPE, so the gowns and gloves and masks, visitor restrictions, elective surgery activity, the kinds of testing we'll be doing, for whether that's rapid antigen testing or staff testing, that will be managed by these phased approaches depending on your location. So the Southwest, Perth and Peel, as of today, have been elevated into an interim amber phase, for example. So the implication of that is that we'll be starting doing rapid antigen testing in the emergency departments in those locations in the next few days. So that changes will occur according to these phased responses, and the Chief Health Officer determines these phases per location. If you've been to a hospital this week, the last couple of weeks, you will also have seen some really visible changes of that. So we've already had some changes to our PPE standards. So all staff in the emergency department, for example, are now wearing N95 masks. We're wearing more eye protection, and that sort of reflects that higher risk level. The visitor restrictions that have come in have been part of that as well, that higher risk settings that we're in. So this is determined by the state, and obviously we then implement that and operationalise it for our hospitals. Next slide, thanks. So I just wanted to, testing is a really important part of both our COVID health response, but also as a member of a community, it's a really important thing to know that you've got testing capacity available, for example. We've been really working hard, particularly with some of our private pathology companies and our hospital sites, to think how we can possibly increase the amount of testing capacity for the community across the health system. So there's lots of different ways you can do that. We're also trying to recruit new staff that aren't healthcare workers necessarily, but that can be trained to be either specimen collectors, so we're calling that swabbers, and vaccination givers, so jabbers. So we're looking for swabbers and jabbers at the moment to really try to expand the number of people that can participate in that response but aren't, registered nurses, for example. You don't need to be a registered nurse to have to do that kind of activity. So we're really looking to try to expand our testing capacity. Some of you may have seen in your communities setting up new drive-through clinics, for example, for testing, and that will continue as we're really trying to make sure we're ready for that as well. Next slide, thanks. The rapid antigen testing, which if you're lucky you can buy in a pharmacy. I haven't seen any actually in a chemist, but you can buy these in the community now. For the hospital setting, the supply will be managed by the Department of Health initially. And so these they're not as accurate as a PCR test done in a lab, but for country, it means that we can do them locally at the point of use. So it gives us a lot more flexibility, being able to get a rapid result. The downsides are that particularly at the moment, when there's not much COVID around, there are false positives with rapid antigen tests. So you can have a positive when you do a confirmation test and it's negative, for example. So they're not without a downside, but they're going to be a really important part of our response, particularly as we get more cases. So the first hospitals in country WA will be our Southwest Hospital, starting using these on Friday in Bunbury, Bustleton and Margaret River, which we've just been in the last couple of days. We're notified of that and are now putting that in place quite quickly. So we'll start to see these used more, and at certain stages of that SAR framework we were talking about, it also gets used for potentially some visitors and some staff and so on. So according to that framework, we'll see more of these rapid tests being used. Thanks. Next slide. The other thing I think is really important to let you know about is that it's not a statewide program, so not a WACS program, but the COVID at home pathway started this week. So most people with Omicron in particular will be able to manage COVID at home the same as they would with most other viral illnesses, potentially with support from their GP if that's required and available. But the department has contracted COVID at home as a private provider that can do, and it's really experienced providing telehealth for COVID patients if they're at high risk of deterioration. So that's many people that are in an older age group or have other illnesses that are at high risk. So this, as I said, has now been activated. There's a website on the health department website. People can register online or somebody can register on their behalf, but only if someone's been diagnosed with COVID already. The people on that program, part of their monitoring, because they're at risk of deterioration, you want to monitor in advance what their oxygen level is looking like, because that can be quite a helpful indicator of respiratory illness. So in Perth, the company that's doing the monitoring have got a courier service to deliver an oximeter to somebody as they get enrolled. And as we can imagine in country WA, that's not going to work. So the Department of Health their aim is to deliver oximeters to all the population at risk, so before they even need to use them, to have them available. And I know that they might already have or in the process of reaching out to many of the local government agencies to see if we can help with that distribution in advance. So I'm happy to take more questions about that, but that's happening through the department. And the other really important thing of the COVID at home pathway is it's a state-run program and it doesn't include residential aged care in the scope of the service. Next slide, thanks. So this is my last slide, I think, that I guess just to summarise where we are in WACS. Obviously, if you're asked to talk about COVID preparedness, and we've been doing it for sort of 2 years, probably missed some of the things that might be important to some of you. But I guess just to summarise, we obviously have ongoing workforce pressures, and we can see that in the near term, we're going to have more workforce pressures because of COVID being introduced into our communities when that occurs. We have done staff surveys, and as our staff in general are feeling supported and feeling prepared, like they have the equipment that they need and so on. And we're obviously continuing to work on that, having a lot of work trying to update staff as much as possible, get information out quickly, continue those practicing and drills and so on. That's really important. The principle that's important to know, though, is that we will continue to care for patients in the best place for what they need. So if someone needs intensive care or a higher level of care support, then just as we would now, if they have COVID, they still may need to be transferred to Perth, for example. We've been working with RFDS. I've just got off a meeting with RFDS this morning. So we're really working with RFDS in St John's to make sure that transport works well. I think the other thing from an organisation, the sort of size and complexity of WACS, is we've done a lot of work on focusing on that central support and networking. So we can be agile, we can be responsive. If there's a need in one place, we can move to help fill that for the staff there and for the communities that they serve and we serve. So really trying to make sure we don't just focus on our staff in one place, but part of that bigger networked whole and how we can support best across all of that. I think that's my last slide. Yeah, so thank you. I'll leave it to the chair if you wanted to have questions at the end or now. It's up to you.
So thank you, Dr. Van Gessel. We will leave the questions till we've finished with the other presenters. So thank you very much. We'll move on to our next presenter. That is Catherine Flower, Acting Lead of the Planning Cell at the State Health Incident Control Centre, also known as the SHIC. Catherine joins us today to talk about the broader planning considerations for health. Welcome, Catherine.
Thanks very much. And hello, everyone from around the state. I think following on from that, the key message there that Helen had indicated was that the responses really has to be managed differently in 2022 to how we plan to manage it because of Omicron. It has changed things. And those common themes that Helen talked about are the same things that we're hearing through our state level jurisdictional counterparts. And the key message really is that, everyone is managing through those challenges. That might be event by event or day by day, but everyone is generally managing through. So from a state level perspective, we sit in that diagram that Helen showed, essentially as that escalation point. So the incredible planning and arrangements and organisation and preparedness that WACS have done across the country, there are likely to be instances where support is going to be required, and that's where SHIC steps in. So from more from a metro perspective right now, we had the backpacker outbreak at Christmas time. That was Delta. We contained that really well. We hadn't planned for that kind of cohort, which made things very interesting at times. They're quite a challenging cohort to work with. But what we're looking at now is Omicron seeding in the community. It started with a return traveller who infected their parents, who infected a worker at a day spa, who infected clients, who infected workers in hospitality and their household contacts, and it's rolling on and on. So at the moment, we're managing clusters in schools, on construction sites, mine sites, nightclubs. And so what is SHIC doing with those businesses to help them? Some of them are managing on their own. They have really mature COVID business planning, business continuity planning. And they don't need support. Some are managing on their own with a little bit of help and advice from the public health physicians or generally from SHIC. Some of those businesses we've had some meetings with and developed a plan of action, and they're delivering that themselves. Some of them, particularly the schools at the moment, have a contact in SHIC who is working with them more regularly to provide advice and support and guidance through managing the cluster in their facility. And in some limited instances, and we haven't had to do this with Omicron yet, SHIC will stand up a multi-agency state-level outbreak management team to support those WACS teams regionally. So right now, we've got a really good handle of the cases, where they are, how they're linked together, but that this is not going to last. We expect that there are already cases in the community, people who've got mild symptoms that might feel like gastro or hay fever. So the question in terms of broader consideration for planning, there are some things that businesses and local governments particularly can be doing now. Obviously, I'm going to repeat the please get your booster shot. There was an announcement yesterday in regards to a booster blitz that's coming. You can be looking at your own local COVID planning, your own business continuity planning, particularly with that kind of overarching commentary that Helen provided in terms of the volume of cases. Look at your workforce contingency planning. Think about your infection prevention and control training practices, measures. Look at your PPE stocks. And from a SHIC perspective, in terms of planning, shortly, there will be an overarching framework that SHIC publishes. It's going to show, explain how cases will be managed and the rules and the likely scenarios for various high-risk settings, so aged care, remote Aboriginal communities, schools, etc. So at the moment, we are still in the phase, the low community transmission phase, where we're still looking at containment where we can. There's some bracket creep now with these increasing amount of cases that we're seeing. And then we will move to this high caseload environment where, as you will be aware from the announcements recently, that the rules are going to change. So it's watch this space in terms of that overarching framework, which I think is really going to help frame for everybody those likely rules and scenarios for some of those high risk settings and what the expectation will be locally and what the expectation will be in terms of what support SHIC can provide. And I'm sure you'll be aware that there is still government decisions to be made in relation to the continuation of mask wearing, density limits, capacity limits, and that kind of key point at the moment where we're just in transition between what constitutes a high caseload environment and how are we going to know when we get there. So that is, again, difficult because at the moment I don't have any firm advice to give you on that, but it will be coming shortly. So I think that's probably it from a state level perspective, and happy to take questions later on.
Thank you, Catherine. We do have some questions, and our COVID response team member, Rebecca Brown, will be facilitating these questions. And I understand that you have colleagues to help assist with answering these questions. Nick Booker, Acting Director, Emergency Disaster Planning, and Melissa Vernon, you're still on screen to help with these questions. Is that correct?
That's right. So Melissa Vernon, Exec Director in WACS, and very happy to answer questions around service continuity, whereas Catherine and Helen will answer any of the clinical COVID preparation questions.
So thank you, and I'll hand to Rebecca. Thank you.
Okay, we've got a few questions. So are any of our smaller healthcare centres or hospital at risk of closure should human resource pressures kind of increase? So things like, nursing staff getting COVID. And if so, would there be a requirement to consolidate efforts into a regional setting or a regional centre?
Yes, so thanks very much. And that would be a first and obvious one to come up on the question. So thank you for those that contributed to that. Look, as has been described, a couple of things. One, as has been described, there is a significant workforce shortage, and that will be exacerbate, and it's international, it's statewide, it's metro, it's affecting all of us, and it's affecting you. You will have a number of services that you're challenged with in terms of staffing. So we are in the same position, regardless. I do want to say that we are in a good position in that, as Helen outlined, we've got a range of telehealth services that have been going for many years. 82, 84 sites is our emergency telehealth service beams into. It's worked for years. It does thousands of cases each year. So that, with a whole range of other services, puts us in a good position and backs us. Like you, workforce shortages are significant. We are constantly talking and planning around what do we do to maintain services if we have less staff at a site, or if we have a site, take one of the small communities where we have a large number of staff actually get COVID or be close contacts. Now, this occurred in Halls Creek and a couple of Kimberley areas last year. I led the rapid response team on that and was up in Halls Creek for a month. So we can respond, and we do respond where we need to with staff. It will depend on what's happening across the rest of the state. So Delta did not spread like Omicron will. So, you know, our capacity will vary. So we are planning around what we can do to consolidate services. We will avoid consolidating services. We will avoid reducing services at all costs. And where we are starting to have those thoughts or conversations, then we are keen to talk with local government and a range of stakeholders. So to that end, the CE and I are keen to meet with Catherine in the first instance, and then to follow up with meetings with all of the local governments, or as many as we can, to actually go through what our thoughts are and to look at where you might be able to help contribute, because ultimately we will all be in this together, and we will need to work together to actually try and sustain those services. Do we have, and I'm just going to predict because it is contentious, do we have a list of sites that we're going to all of a sudden close? No. Do we want to close small sites? No. If we do change the service model, we will change it temporarily. And this is one thing that the CE and I will absolutely reinforce. There is absolutely no covert action underway to reduce small services or close small services. We will do our very best to keep every service going. The truth is, we know that we've got significant staffing pressures. And at the moment, we have pretty much all our nurse managers and those that are in leadership roles working in clinical roles. And that means if someone calls in sick on a day, then all of a sudden we're really, really short and we need to modify and move. So a bit of a long answer, but I hope that deals with some of the questions that might be pending.
Yep, I think that you've spoken to some of the questions. So you identified that there's been a real pressures globally on staffing. So one of the questions we've had through is, you know, there's been accusations that the Premier's had 2 years to get hospitals ready, but that hasn't eventuated. From what you said, you guys have been prepping for quite some time. So have you got any comments on that?
I will. So clinically, you can see what the clinical leads have outlined and what we've been preparing for. We've also workforce-wise. So again, the telehealth development backs up our services and did really very well through Delta, as it has done for 2 decades now in a number of areas. We've developed up partnerships with the metropolitan hospitals, and that's been in place now probably for the last 3 months, where we meet weekly and identify what our staffing needs are. We have a number of probably about 70 or 80 staff that are either have been or will be going out to country in a rapid deployment way. Now, the challenge is as the pressure comes on the metro, their capacity to release staff is lower. We've also got an arrangement with our statewide Nurse West agency, and they prioritise country needs over metro, because a small hospital of a loss of 1 or 2 nurses is much more significant for that community than, you know, half a dozen or a dozen in a big teaching hospital. So on that basis, there's those supports. We've also gone to 7-day quarantining for health workers coming from interstate. So that's down from the 14, and we're rapidly moving those through for Chief Health Officer endorsement so that we can get them into the state, and we have a number of those. Look, in country, we have had a high dependence on overseas interstate, particularly workforce, and you will know that perhaps yourselves in your own experience. The more remote you go, the more you're dependent on agency and fly-in, fly-out services. We're really trying to avoid that as much as possible, but in this world, that will be our reality.
Okay, thank you for that. We've spoken a little bit, you've outlined, or some of the speakers have outlined about preparedness. What do you see the role of local government in terms of the pulse oximeters and the distribution of those? We know some local governments have already been approached to be a distribution point.
So Helen might like to cover that one, other than we're keen to work with you, obviously, but there may be different perspectives on your capacity in that respect as well, and we respect.
So I think the central department were and I have approached some people already, and some have been approached through OASGs. The thinking was that what organisation or agency is actually in most places around the state, their idea is that if we can get delivered, if you do an assessment of a town that says there might be 100 people that are at risk of severe COVID, so whether that's by age group or whatever, how can we get the oximeter, which is a finger-sized bit of equipment, to that person in advance? And so the idea was that if we can deliver them to local government, then people could pick them up from there in advance. But it's an idea that needs a conversation. So I said the department is sort of having those with people, but that's what the intention is as far as I understand. And I think some of the Southwest maybe that's already commenced. So we do have oximeters that have been delivered to hospitals to have in preparation if we need to deliver them. But I really think it would be better, if possible, that someone has the oximeter in their house. Then if they get diagnosed with COVID, they've already got it. They don't need to then have someone driving around trying to find one, have them delivered, all of those things which can take time. So that's the concept. If you haven't heard about it and you were interested, then I'm happy to be contacted, and I can pass that on to the person in the department that is coordinating that.
Thank you for that. Quite a clinical question. So in the various options in terms of restricting entry to, for example, hospitals, are you still taking temperatures? Is that still part of the process? And if not, why not?
Yeah, so good question. We had this discussion yesterday too. They've done quite a lot of looking at the evidence of temperature checking, and it seems that in almost every setting, whether that's airport screening or entry into buildings, it's not very accurate and it's not very effective. So a lot of people, it doesn't pick up the cases you would want to pick up. So most people now that had stopped it, which is interesting. So there is a really nice literature review that one of the New South Wales Rapid Evidence Review, and that's with their conclusion when they did a kind of around the world literature review on that matter. So that's interesting, isn't it? Because we've all thought about that, particularly some of our community health settings for the same thing. Maybe that's what we should be doing, but it shows that it probably takes time and effort and doesn't actually deliver what you need.
Okay, that's very useful. We have a follow-up question on the pulse oximeters, and this may be a discussion that requires a sort of taking offline, but how was it envisaged that the oximeters would be prioritised? What would be the sort of criteria for their use?
So the people that are eligible for the program are people that data would suggest are at higher risk of having severe disease. So that's anyone over 65 or over 50 if they're Aboriginal, and we can get those kind of projection of numbers from pretty readily available data, obviously, so we've got a pretty good idea of numbers wise in all of our communities. And then the number of people that have got active cancer, significant lung and respiratory type of illnesses, so a number of other comorbidities as well. So we know those people that would be eligible for the program. We just want to make sure we can get the equipment to them in advance if possible. So whether it's a system of having to show your birth date to say you're eligible to pick it up, I'm not sure the operationalising of that. As I said, it's happening through the department, but I think that from a health point of view and a clinical point of view, I think the concept is a really good one, if possible.
Thank you very much for that. So obviously local government is an employer of quite a number of people. So there's a question, is there a plan to provide guidance on the type of information that will support employers for dealing with COVID positive employees? For example, things like checklists or interview scripting to help them engage both while they're obviously off work and then when they return to the workplace.
Catherine, is that a question for you or for us, or how do you want to?
So the document that I alluded to, that framework that is going to explain the kind of rules and responsibilities, that is intention is to outline that information for employers as a central point. It won't all be, it won't be all encompassing for everyone, but that will give you a really good framework in terms of what the expectation is and how to have those conversations and what those requirements are.
Fantastic, thank you. And I just, we've had a question, so just confirming that we will be sharing the presentation. So there's, again, I think the pulse oximeters are coming up quite a lot. For communities where there's a high number of people over 65, will there be enough? How many have the department ordered?
They've got plenty. So I think for the Southwest, I think it was thousands, and they're being delivered as soon as possible. So there's a lot that it's available, which is good because they're often not available in chemists anymore. So if people are looking for their own, it can be a bit tricky. So there's a really good supply. So we want to use those if possible, so people aren't getting concerned thinking they have to find their own.
Okay, the colour coding system that you put up earlier for hospitals, is that something that's going to be publicly available? Is it something that local government should be informing their residents about?
I can take that if Catherine might want to add as well. So it is publicly available. It's up on the Health Department website now. And there is, my understanding is that it's anticipated it will be also available like as a which area is in which zone as a publicly available document as well, because that would be important, wouldn't it? So you'd know, particularly if you've at a time of change. So if you've changed from amber to red, it means that there's no visitors allowed in the hospital. It's a really important public messaging thing. So we're keeping on trying to use our social media to try to reinforce those messages as well, and so on. But yeah, so that's going to be publicly available, and then I think what we're looking at is how can we sort of translate what's sort of quite a bureaucratic table into what that means for the public, and to try to get that out in a meaningful way as well.
Okay, what else could local governments do to help support their local communities? Obviously, in the regional areas, local governments play a whole host of roles compared to sort of in the metro. What are some of the things that that you were thinking about? Melissa or Catherine?
I'll start while Catherine and or Helen respond, I think, through their answer. Again, we're really keen. We're going to look to actively engage with you. A number of you are on OASG meetings with health and police and community, Department of Communities. So keep working there. You'll be involved, you'll be engaged. I know when I was up in the Kimberley that we met frequently. Certainly at the local level, we had a local group that met frequently as well. So as things, as activity increases, then certainly in Halls Creek, we were meeting a couple of times a week just to make sure, and then on a daily basis to make sure everyone was up to date. So that's at the acute end. From a workforce perspective, we are very keen to meet with you, and I will give my, you can contact me anytime. I'm not so good at 1 a.m. in the morning, but I will give you my phone number. If you are concerned about any issues with regard to service continuity, then I'm happy to take the call and make sure that you have the right information. So here it is, it's 040 8939 228. So that's I am very serious about this, because I know that the greatest fear in country communities is that you will lose a service, and we will do our best to enable services to continue. But we do know that that may not always be possible, and we want to involve and engage with people. So working with us. We also, if this peaks, as it has in any way, like in the other states, then we want to be working with you about support for our services. So do you have people that can support us with being an orderly, support us with swabbing, transport, all those sorts of things that will help us to keep a service going, because it won't only be the nurses and doctors. In Halls Creek, I spoke to the cleaners and I said, you think the nurses and doctors are going to save us? Actually, it's the cleaners that will save us. It was keeping everything spotlessly clean, all those public health measures. So that from WAC's perspective, that's what I would be hoping that we'd be able to talk through.
Thank you very much for that incredibly generous offer and for giving out your phone number to over 100 people online.
I would take it rather than have anxiety and agitation about things. You know, it's better to check and check with the source.
Oh, fantastic. Thank you. We've got a couple of final questions and then we'll wrap up. So just a quick one. Is there any suggestion that carbon dioxide monitoring is an effective control in terms of identifying whether there is sufficient ventilation in a building?
Catherine and I are probably both looking at each other. So there is. I mean, it's been a pretty interesting area over the last couple of years, this whole thing about airborne transmission and so on. There's some evidence about carbon dioxide monitoring, but it's actually really complicated because it depends how many people in the room and a whole lot of circumstances that you might measure at one time, and under different circumstances, the same room can be different. We know that the Education Department have been using that as a way to understand where they need to increase ventilation in their classrooms, but it hasn't been shown to be as useful when you've got rooms very different. If it's an ED that's got 20 people in one common space, than if you've got one engineer testing the carbon dioxide one day. So it is a tool, but it's not the be all and end all. And we've had mechanical engineers go through all of our facilities, look at all the airflows, look at all the ducting, look at everything under a whole range of circumstances to try to understand that. But it's a complex area, that one that I never thought I'd have to understand as much as I now have to understand, apparently.
I think that's common with a lot of COVID-related things. We never knew we'd be experts in this. Just finally, we had a question about local governments registering for the pulse oximeters. My understanding is that local governments are being approached on an individual basis through Department of Health. So if you haven't heard from them yet, you may in the coming weeks. So I think that is all of the questions we've had.
Thank you very much. Before we finish up this morning, I want to take an opportunity to thank all the presenters once again for their willingness to engage with the sector and to answer the questions. The information that we've received this morning is so valuable, and your offer of continued communication is also very welcome. We'll continue to keep you in all local governments informed of any further developments through our COVID updates, and please do reach out to the COVID response team at Wellbrook if you have any further questions. And we will consider a follow-up of the same webinar in a coming week. So thank you, everybody, for your participation this morning. Thank you.